You ready?
Oh, hey, Chris.
Hey, Chuck, how are you?
I'm good. Thank you. How are you?
Noticing that you've got a little Peloton swag on right now.
This was my birthday present this year. I'm not a big gift. I'd like to give gifts. I don't always, I don't need to receive gifts. And I'm not the Peloton master that you are, but I do enjoy a good
Was
Peloton.
was that a subtle hint by somebody that you to get your ass on the bike or
No, you know what's happening is because I currently don't have a car because of an adverse event on the road. I
car misadventure, as they say?
Yes, and I do have a car on order, but it's gonna be a while. I am biking a lot to work, and I have to say I am enjoying it, although biking in the dark in the morning is not my favorite. And so I've been on the Peloton a lot less lately.
I will say that terrifies me, as we've mentioned in prior episodes. I know we have some listeners. Shout out to Sam Mugdeteri who bike to work, but that terrifies me to do that on a regular basis.
But you were in a good spot too. I mean, you can really just go through the park, but we're getting off topic.
Yeah, I think that it's kind of, it'll depend on the day. Sometimes there will be days that will allow that to happen, and other times not. We'll see.
Yeah, you have other issues too, which is little kids running around the house. I just get up and go, so it's less encumbered, so to speak.
So we have another great review. So thank you to everybody. The reviews are pouring in and we love it. We will say the last episode, we read a review and answered a question from Matt, a medical student at Mayo. Matt, if you're listening and you want a mug, send us an email. We don't have your email address and all that kind of stuff. So handpodcast@gmail.com to collect your mug. And when we were talking about dishing out your mug, Chuck was like, well, let's see if he really listens. So that's your first Chuck Goldfarb WashU test.
Absolutely. And then we'll get in touch with our shipping boy. Oh, that's me. That's me.
Yeah.
I'll get that out real quick if you
I don't know if you guys realize the imbalance of labor here between me and Chuck, the podcast editor / I never heard this term shipping boy, but
well, shipping boy is a derivation from one of my previous non-hand surgeon duties, which was belt boy. So let me explain what that means. And this is a subtle or not so subtle plug. So my wife has an incredible business called Myself Belts. We should have her on as a guest, maybe, or is that awkward? Anyways, Myself Belts is a one-handed belt which she developed and patented and started a company around many years ago when my oldest was potty training and could not keep his pants up. And so the belt business has been great. She was on Shark Tank. It's a really interesting story, I think, objectively. And so early on, she would go to the lake during the summer. And that's when there weren't a ton of belt orders, but I would come home every day after work and there'd be 10, 12, whatever orders. And she would say, okay, we'd be on the phone. Maybe not even cell phone back then. And and I would ship belts. And so, it was kind of satisfying. You kind of just get the work done. But I got tired of being the belt boy.
I'm pretty sure that the belts were shipped with maximum efficiency, shipping 2 belts, staggering the room so that the belts were shipped appropriately.
Excellent point.
Never overlapping, but perfectly sequenced, those belts.
Well, the problem was I would go down, we had a little belt storage area, and I'd go down to the belt storage area, and because I wasn't, in that room every day, I didn't know where they all were because there's multiple different styles. And so I'd call Talia cursing about where's the sailor belt or whatever, and she would laugh and we would yell at each other. It was great. Good times.
Yes, the old days. So yeah, I think that would be great to talk to Talia. I've always wanted to talk to her about her Shark Tank experience. I think that is such a relatively unique, not many people know somebody who has been on Shark Tank. So that's pretty awesome. And maybe if you recall off the top of your head, the episode, we could point our listeners to it at some point.
Yeah, no, it's season 6 is all I know. It's brutal. Let's just say I'm not a fan of all of the judges. The teaser, though, is if you're a Shark Tank fan, and many are, Mr. Wonderful's a good guy. He plays a character for reality TV, and it is reality TV, but it's kind of hard to watch. But she got a deal, not to be a spoiler. So all ended well.
Chuck, are you playing a character right now? Is this reality podcasting?
I am playing a character now. This is not the real me.
So we have a great 5-star review from Mark Grayson. So thank you, Mark. Terrific podcast, guys. I just graduated from the UCLA Hand Fellowship and wanted something to listen to on the long drive to my first job in Colorado. And what a find. So thanks for finding us and good luck with that job. I crushed about 15 episodes and enjoyed your thoughtful insights and good humor. And I almost felt like many of the episodes were tailor-made for someone in my shoes. I will be tuning in regularly. So
Ah,
awesome.
that's really nice, and I say congratulations. I don't know there's a lot of jobs to be had in the state of Colorado, given how popular it is. So, congratulations and enjoy it.
Yes. Enjoy the new job. Good luck settling in. And as questions come up, if they do in your practice, and you want to, kind of talk to Chuck about it because he's the seasoned OG, send us an email, handpodcast@gmail.com.
Yeah, please do. Please do. We would look forward to it. It keeps it lively here because you, the listeners, have different challenges and different questions than Chris and I do. We live in a somewhat insulated environment, and we like to think we know all about different practice environments and practice challenges. But the reality, of course, is that we do not. So write us.
Yes, and feel free to address your questions to Shipping Boy. So today, Chuck, we're back with the Wheel of Hand Surgery.
Oh my God. We're turning off listeners left and right.
No. I will read a comment that we have at some point from a listener who loves the Wheel of Hand Surgery and actually requested that we film a little audio segment based on the Wheel of Fortune, where people are chanting Wheel of Hand Surgery. So if anybody's listening, wants to contribute to that, we can mash it up. It would be great. I'll get my editor on that one.
That would be me. Unlikely to happen. But if there is a tech-savvy audience member, that is definitely mug-worthy.
Yes. Oh, that would be great. That would be great. So if you remember, we have our wheel. And for those of you watching on YouTube, here is the high-tech wheel. Incredibly high-tech. So we did replace one topic that we covered last time. We covered slack wrist, so that went by the wayside. And we've replaced it with a sportsy topic because I know that's what you and the listeners supposedly want. But we have topics here that have been contributed by former fellows Shobit Minhas. So thanks, Shobit, if you still listen. I know you listened before the fellowship and during the fellowship. We'll see if you listen after the fellowship. And Lauren Wessel and Ruba Sokrab, as we mentioned last time, have contributed to this. So I'm going to spin my pen on this, again, high tech, and we'll go from there.
Are you closing?
What do you not want? No, I'm not closing my eyes. I can't spin the pen and close my eyes. Come on.
I don't know what all the topics are. I couldn't see.
All right, so So again, the topics to review: networking, favorite instruments / preference cards, prepping for new cases, as we kind of alluded to last time. Didn't see that coming. Acute SL injuries, and never have I ever with blank.
Oh God, there's certain ones I'm hoping aren't picked in this wheel of hand surgery.
What I haven't spun yet. What do you not want to discuss? Because I'm gonna communicate with my wheel saying pick that topic.
Never have I ever. I'm just not sure where to go with that one, and didn't see that coming. Kind of violates one of my internal credos of "don't be surprised." But
well, you're the fellow that was with you on your service at the time of creation of the wheel is the one who picked that topic. All right, here we go. I will close my eyes. Spinning the wheel. Okay, so it's kind of in between. I think it's more never have I ever with. I'm actually going to take a picture of this so that we have
perfect. I need
proof,
evidence.
And hold on a second, quick edit here. And I will show this to you. Can you see it? No, probably not.
Not really.
Not really.
No, you can. Nah.
All right.
See. I trust you.
All right. So never have I ever with blank. So what I meant with this was, what are the things that are considered taboo in practice? Safe for common conditions. And this came from one time where we were on Twitter and we were talking about what we do for tennis elbow. And people were talking about whether they do steroid shots, whether go to the OR, PRP, all this kind of craziness. So I guess there are a few topics we could address here. Can you think of anything that in your practice that you don't love to truly fess up to, but you actually end up doing?
So these are things I do that maybe I keep on the down low, or
Yeah,
things that I don't do because I really object to them.
either one, but probably more the first. This is the insider knowledge.
Sure. And this is not
Stuff,
going to,
stuff that's maybe considered taboo in the literature, but you're like, God, it works.
well, I think just building on what you already said, this probably is not going to come off as controversial, but it does violate my reading of the literature, is I do give steroid injections for tennis elbow. Um, I will say that they are never my first choice. I always send patients to therapy. Um, and let's be honest, therapy may work, but I'm not sure if it's therapy or just time. And I send patients away. And if at 3 months or 6 months or longer, they still have symptoms, they are really unhappy. They're asking me to do something. I certainly don't want to go to the operating room. And so I offer a steroid shot. And as we all know, there are times when it's a home run. I warn patients that it's likely to come back and they should use their pain-free interval for stretching. And I warn patients that it could come back worse. But I don't lose any sleep over that decision. And I don't know what your reading of the literature is and what your personal practice is, but I'd be interested to hear.
Reading of the literature is that it's time, and that I don't know if it's the steroid shot or the fact that something is being injected, because there are plenty of papers and high level studies showing that injection of a placebo is effective. And I don't know if that's, again, the fact that the psychological benefit of somebody is doing something to you, or maybe it is hydrodissection. Maybe that is useful. And I don't really know. Um, I have given more, I tried my hardest when I came out in practice to follow the literature. And the literature has really piled on to the fact that it is time. But that's a really hard discussion to have with a patient because, tennis elbow sucks. Like it is a condition that is bothersome in every aspect of your life. The only time I'm not old enough like you, Chuck, to have tennis elbow, but the only time that I had was close to tennis elbow was a substantial amount of yard work one weekend. And I was like, shit, this would really suck if I had this condition. So I don't know. I mean, I think that I tried very early on not to do things like steroid shots and not to operate, but I give steroid shots now, but I still feel weird about it.
I absolutely feel weird about it. I absolutely discuss the literature with the patient. It makes it feel more appropriate to me if I share why I'm hesitant, because most people come in saying, give me a steroid shot, please. And I talk them out of it, and most people are amenable to that to start. That's the benefit of being older. And we could do an episode of all my ailments, like tennis elbow. If that's interesting to the audience, let us know. My wife would definitely not tune in. What about
Talk about reality TV.
what about PRP, or what about dry needling? What about, do you send any of your patients to our partners or anyone else to consider such injections?
So I think that if anywhere in the sports orthopedic musculoskeletal world there is a suitable indication for PRP, it is tennis elbow. I think there are a number of studies that would support that. I think I saw one patient for PRP one time, because we actually in our department do have, the setup to do that. It's just honestly, it's expensive, and most patients don't have the means to do it because at least my impression of it right now is that it's not typically covered under most insurance plans. So, do you have any thoughts on that? You're a little closer to that in terms of the finance part of it than I am.
Well, first of all, I mean, we should do an episode on alternative treatments and some of the challenges in the St. Louis community and in all communities I know about charging patients for unproven therapies. It's really super interesting. The FDA is I don't want to go down the rabbit hole, but the FDA is going to come out with some recommendations about this, and there's some really concerning things that go on. I think PRP is very reasonable for the patients that I can't get better. we are lucky that we have Dale, Colorado doing injections and trying to create a center for appropriate use alternative therapies. And he's done a great job with it. And I think that I feel very comfortable sending my patients to him, one, to be evaluated for appropriateness, not just a knee-jerk reaction, and two, to do it under the guidance of the best literature.
Well, I mean, you said, unproven therapies. I guess I would probably not put PRP for tennis elbow in that category, but I would put it in the alternative treatments category.
That is totally fair, and I didn't mean to convey that. There are lots of other things going on out there that are unproven, but you are correct. That is not. I think PRP is, a reasonable approach.
So where does this fit in your algorithm, for injection and then maybe PRP and then surgery, or who skips the PRP? I mean, how routinely are you recommending the PRP, and then how many injections before you consider surgery for this condition?
Oh, I'll share my algorithm without great confidence that it is the algorithm. I have great confidence in other things that I do, but I would say that patient walks in, he or she may have 6 or 8 or 12 weeks of discomfort. I recommend one visit to therapy. I go over some things myself. I let the therapist go over things. I talk about activity modification, supinated lifting, and lots of stretching. I ask them to come back 8 weeks after the first visit for a reassessment if they are not getting better. If they are getting better, I tell them to come back if they need me. If they come back and they have failed therapy and they're not making any progress whatsoever, I will do a steroid injection. And I typically only offer one. However, as you
Do
know,
you bring that injection up, or do you let them bring it up?
on the first visit, I bring it up to explain why I'm not doing it. It's pretty rare that people walk in not knowing about the steroid injection option for tennis elbow, in my experience.
And then if they've already done quote therapy, do you investigate further as to what they've actually done, or ask the therapist that's with you in clinic collaborating with you? Do you ask them to investigate more, or do you give them a pass and give them credit for having done therapy?
Depends on the patient, but I absolutely try to learn more about what they have done. And again, I want to say negotiation in a bad way, but I'm not going to let this turn confrontational. If a patient comes in, feels that they have done therapy and are asking for something more, and a wrist brace hadn't worked and a counterforce brace hasn't worked, what else do we have to offer? I don't think I'm doing harm with a single steroid injection. I do think we can do harm with multiple steroid injections, but I don't think it's some great crime. And I think there's a chance you knock it out of the park with a single steroid injection.
So where you'll do one steroid injection, and say they come back, I don't know, 2 or 3 months later, they got some partial relief, but it's still nagging them, it's still bothering them.
I do investigate onto whether they did use what I call the pain-free interval to work on therapy exercises and stretching and strengthening. And if I'm comfortable with everything, I discourage a second injection. I will admit I will do a second injection. I will not do third, fourth, or fifth injections unless circumstances are highly unusual. But that's when I start talking about the other options out there. Surgery being one option, PRP being another option. But I wouldn't think about surgery for most patients till at least 6 months of failed intervention.
Now, do you bring up PRP in terms of, you say, here are the other options, and how do you tell them about PRP, and also balance that with the admitted cost that comes with that?
I just lay it out there. I kind of briefly describe that it is supported in the literature, at least somewhat, that we have one of my partners does it, although you can also get it in the community. It is out of pocket because insurance companies don't buy in. And it's just another choice. And for some patients, they've heard of it and it resonates. For other patients, they have no interest in paying significant out of cost dollars for a treatment that's not, frontline, so to speak. At least for me, it's not frontline.
So imaging, are you getting an MRI at this point?
No. As long as everything else lines up, I want to say, I don't think my treatment has ever been modified by an MRI in this situation, because some patients, work comp will get the MRI or they'll demand an MRI. And again, if I think there's potential, I don't always fight it. I don't think an MRI has ever changed my treatment. There could be a problem with the extensor mechanism. There can be a quote unquote rupture of the extensor. It doesn't change my treatment.
In terms of the never have I ever realm, I have acquiesced to patients who feel like some imaging would be useful for them, even though I know that it's not going to be useful. And again, like you're saying, like the literature would support not getting any additional imaging, and certainly from a societal cost level, not getting an additional imaging would be useful. But not wanting to get into a confrontation with a patient, I try to stand my ground. I tell them the reasons why, but in some patients, they really, really want it. And I will admit, I give in sometimes.
Yeah, look, I mean, we would. It would be interesting to see if our payer model was different, whether you and I would give in. I do often negotiate and say, okay, let's give therapy 6 more weeks. And if you're really not turning the corner, call before your visit. We'll set up an MRI and we'll go from there. So I do try to push it out and potentially make it disappear. But let's be honest, tennis elbow is not complex diagnostically. And people like you and me are a dime a dozen. I mean, there are lots of providers out there that will take care of a patient with tennis elbow. And I want to take care of patients. I want them to value our practice, and I want to have a good relationship. And there are people listening, a few at least, who will shake their head and disapprove of our choices here. There are many others where I believe this is how they would approach it as well.
I think if you mentioned this a bit, but I mean, if we were in a bundled payment for tennis elbow, I think there would be much more streamlining in how we took care of these patients. But reality is, we're not in a bundled payment for tennis elbow. And I think there's a lot of nuance in how you manage some of this, just mainly getting the patient through this process. And like you're saying, the longer you kick the can down the road, the more likely the patient will, quote, regress to the mean, as many of the papers have said.
Right. All right. So we got to do a never have I ever for you. What is something that you do, although maybe cover your eyes when you do it?
Um, I will, I don't know, this isn't that taboo, but I will denervate for tennis elbow. And I think we talked about that a little bit. So that'll be one thing I'll give you for tennis elbow. And then I will, if I have a patient in whom I have done a trigger finger before, a trigger finger Wallant surgery, I will let them skip the steroid shot if they've already loved their surgery. And honestly, a lot of times they tell me that the Wallant surgery hurts less than the steroid injection for a trigger finger. So I will allow them to bypass the traditional, I'll give you 1, 2, 3, 4 steroid shots for your trigger and just go straight to surgery. Because I feel very good about the predictability of that surgery.
Well, for your second one, I don't think that's crazy at all. Many patients do not want to go down the trigger finger injection path again, especially if it has led to surgery in other fingers. And so I agree with you, especially office-based trigger release. But even if it's in the OR, I don't think that's crazy at all. I have zero experience with your other point, which was denervation for tennis elbow. And I know we've discussed it before. So again, I don't go hiding your head in shame on that one. Remind me exactly what you do for that. I'm curious.
So, Dellin described, I think it was in Journal of Hand Surgery, late 2000s, probably around turn of the decade, and well, the last decade, the 2010s. So there is a small cutaneous branch coming off of the radial nerve, that you can find pretty reliably. Some people actually describe that branch when you're finding the interval for for an anterolateral approach for radial tunnel release. So that posterior cutaneous nerve of the forearm that sits between the BR and ECRL, that will oftentimes also provide a branch to the lateral epicondyle. So if you keep tracing that nerve up, you'll see where you can denervate it. So that, and the paper has some very interesting kind of anatomic maps. So I think that is useful. I find that branch. I actually will send them for an ultrasound guided injection of that branch to see how they feel about it. And usually this is for like the recurrent case, maybe a failed prior tennis elbow surgery, which we could talk about too. And and like we mentioned before, I have a low threshold to release the radial tunnel. And again, probably along this kind of campy never have I ever. I like doing that surgery, and I think that for these patients, you want to be done, done, done. So my predisposition towards addressing the nerve issues has led me to pretty much in most tennis elbow cases, you're not getting an isolated tennis elbow surgery with me. You're getting a tennis elbow radial tunnel release, and in some severe cases, the denervation. So I cut that branch going to the lateral epicondyle, and I bury it within a head of the triceps, tuck it into the triceps, very loosely close the opening in the muscle with a 3-0 monocurl on each side, not to create a point of compression, of course, just to make sure it doesn't displace, and then I'll tuck it in with some fibrin glue.
Interesting. Yeah, I have, like I said, zero experience with that. I don't see tennis elbow surgery the same way, although again, my results are not perfect, so maybe I'm missing the boat here. But I will absolutely prefer. First of all, I don't do many tennis elbow surgeries. It is definitely less than 5 a year, and I see a fair amount of tennis elbow. Um, and if I do 5 tennis elbows a year, probably 2 are with a radial tunnel, and those are patients that have inordinate pain over the radial nerve, or radial tunnel, I guess I should say, as well. And so I will do isolated tennis elbow if there's no radial tunnel pain.
Conversely, do you do isolated radial tunnel?
I do. Yep. Yep. Again, super rare. Again, a couple a year, I would say at most.
I feel like, if you're doing an isolated radial tunnel, it's just so easy to do the tennis elbow part of the surgery too. And in most of those patients, they have just some element of that anyway. So admittedly, I will probably end up doing, the tennis elbow part. And to me, that involves, debridement and sometimes tenotomy of the ECRB as it comes off of the lateral epicondyle. Is that how you approach it, or do you do it differently for the tennis elbow part?
For the tennis elbow, I don't specifically perform a tenotomy. I generally ellipse out what I consider visually unhealthy appearing tissue, and I try to stimulate kind of a bleeding or healing response on the lateral epicondyle and lateral aspect of the capitellum. So a little different. I know some people will truly tenotomize the ECRB origin, which I think is fine. I just don't always do. I don't routinely do that.
How do you simulate that healing response? Are you using a curette or something like that, or?
I use a curette, sometimes a rongeur. I'm not opposed to drilling, but it's just easier to use whatever is on the set.
Okay, scope?
Yes, yes. I've said this to fellows before. When I was starting my practice, when I was clinically not as busy as I wanted to be, and the literature certainly is supportive of arthroscopic treatment for tennis elbow, I did a fair number of arthroscopic tennis elbow debridements. And I will do it today. And I have, in the past year, done a few. The negatives of that are it takes more time. It's a bigger deal for the OR. Both the setup takes more time and the procedure takes more time. But the benefits are, you can rule out intra-articular pathology if you have a reason to think there might be intra-articular pathology. And that's the patient that I will tend to do it on today. And you can really effectively treat tennis elbow, I think. And I've had very good results with it. As you're building your practice, it's just a nice way to do elbow scopes. If you want to build a practice that includes elbow arthroscopy, this is a great way to increase your comfort level with the procedure. Obviously, taking great care during the process to not have adverse events, but it's a great way to build that skill set.
Elbow scopes always make me so nervous about the nerves. I'm just, I've seen it go the wrong because of I see the other end of it. And fortunately, it's great that our fellows get that experience. I remember going into the rotation with you and seeing way more elbow scopes than I ever thought I would see. So I think you
Well,
were on one of those tears where you were doing a lot of the, osteochondral defect stuff, which is really cool.
it's funny, Elspeth Hill is our one of our fellows this year, and she has started her rotation with me for 2 months. And she is a plastic surgeon, and she has a wonderful attitude and has very little experience with elbow. And I have to say, I don't know that elbow is her true interest, and it seems like I've been seeing in clinic and in the OR a lot of elbow, so I kind of feel badly, even though it's one of the things I enjoy. I have the other direction for never have I ever is procedures I really don't like to do, and really try to avoid, and sticking on the arthroscopy course. I may have said this before, I don't really like and rarely do diagnostic arthroscopies. Um, I just think in 2021, it's almost never indicated. Now, it's not to say that I know with 100% certainty every time I do a scope what I'm going to find and what I'm going to do. But for the patient with vague, unexplained pain, it is pretty darn rare that I offer a diagnostic arthroscopy to solve the problem. Thoughts?
It's interesting. I had a patient who came in to see me recently who has kind of vague wrist pain, and we were talking about it, and she had, I think I was a third opinion, and she was saying that, somebody had said, "Well, I can't explain why you have this amount of wrist pain, but why don't we just go ahead and explore and see what it is?" And I think probably the procedure they were describing was a diagnostic arthroscopy. And it gets to the kind of sports magic of, the therapeutic lavage, uh, probably helping quite a bit. And, the splinting after surgery. And I guess at the end of the day, if it's what makes the patient better, fine. But I don't love the idea. I'm with you on that. Our worlds are different, but the diagnostic exploration of a nerve, I think is, something that I don't think we do, but I also know that we go to the OR and the OR information gives us diagnostic value. So confirming the extent and location of the nerve injury, but all this stuff has been really assessed very thoroughly with serial physical exams, with electrodiagnostics, ultrasound, all those things. So it's just adding another element to the workup and trying to figure out, the prognosis.
Yeah, that's interesting. I want to hear more about that, but I will say the patient for whom a diagnostic wrist arthroscopy makes sense for me is a patient who has vague pain. I have given a diagnostic slash therapeutic corticosteroid injection to, and who responded really positively to that intra-articular injection, but the injection wore off. If I don't know what's going on and I give a steroid injection and it doesn't help, I am going to tell the patient I can't help you. If I've really exhausted everything, and it doesn't happen often, but I don't think a diagnostic scope is appropriate in that case. So going back to your scenario, I guess I might say for radial tunnel, you said you will use injections to help with the diagnosis. And so if you've exhausted everything to make a nerve situation better, what will you find? And what percentage of patients where you do an exploration for nerve, diagnosis, do you find pathology?
I mean, it's not for compressive neuropathy. It's in a setting of a nerve injury.
I see.
And for example, in a brachial plexus, one of the big differences based on who you see is whether they would explore the plexus at the level of the neck, and whether it is to find, use it as a treatment in terms of finding a viable nerve root that you can use for grafting. But, one of the things that was, big when I visited Changgung in Taiwan was the exploration is the last part of the diagnosis. I mean, you think you've honed in on your diagnosis, but as everybody knows, the ways that we assess nerves are really imperfect. So there is no 100% perfect way, but if you find that truly there is a 5-level avulsion and you see it with your own eyes and you can confirm that, that's just helpful to tell the patient we looked. Or you find one nerve root, be like, look, here's how bad the injury is, we did find one nerve root. So I think there is the exploration and the surgery is part of the treatment. And I have a good sense of what I'm going to do, but confirming my diagnosis is essentially what's happening. Or for example, say, like we've had a run of recently, sciatic peroneal tibial nerve gunshots. We had a really interesting case where, we talked about it, and we do this really cool conference where we have people from Changgung and people from London and our group in St. Louis log in. We talked about a case where there was a gunshot essentially to the sciatic nerve right at the bifurcation of the tibial and the peroneal nerve. And there are two gross types of nerve injury you can have from a gunshot. One being, the fascicles actually being disrupted by the bullet, and then the other being the sort of concussive injury, blast zone injury to the nerve. And it actually went through the peroneal nerve, but then had a blast injury to the tibial nerve. And the discussion and debate on the call was, do you manage those differently? Do you give the tibial nerve time to recover, just do a neurolysis, or do you excise and graft both of them, knowing that, the concussive injury to the nerve is far worse? But, that's information that you can't really glean from, preoperative electrodiagnostics, directly. Ultrasound helps and was really helpful in this particular case. But there's nothing like an exploration to say, look, this is what is actually happening.
I love it. And did you explore this patient?
Yeah, it's a great case. I mean, I know we're on a hand surgery podcast, but it's exactly what we suspected based on the clinical exam and the electrodiagnostics and the ultrasound. And the bullet had gone through the perineal nerve and had a concussive injury to the tibial nerve with, essentially a high grade axonomatic injury to that tibial nerve. So they both ended up being excised and grafted.
Gotcha. Awesome. All right. Well, let me flip it back on you. I gave the wrist scope example. So never have I ever, what procedures, and I can, if you don't have anything that immediately comes to mind, what procedures do you not regularly perform that you know are performed in the community?
I'm trying to think of things that come to mind. I mean, I don't do DARAs a fair bit. It still makes me feel a little weird to do the DARA. It's a hard thing to explain to the patient. Well, why does this hurt so much? What can we do? Well, we could cut it out. Uh, and I'm still baffled a bit by how that surgery really works as well as it does. And I admit that I have struggled in my practice with the instability of the stump. Although we have partners, everybody manages it differently. Some of us are very intent on using things like hemislips of ECU to stabilize it from the jump, but others are like, yeah, just let it go and it's fine. And it's just, I struggle with that surgery, and it doesn't really quite fall into the never have I ever. But that's a surgery I was reflecting on recently because I just indicated somebody for it because I think it's a good solution for that problem. But I don't know. Do you have any thoughts on the DARA?
I've been around long enough to see all kinds of different solutions proposed for issues at the DRUJ, and matched resections and stabilizations and DARAs and Sove, Kapanjis, all kind of different things. I would say right now my solution is the DARA, but I totally feel the same way you do. I don't love it. I have a difficult time explaining it to the patient, and I really worry about instability. And the other thing I tell the patient, though, is that it's been around for 100 years. And there's a reason for that, I think. And so I typically do two things. One, I release the pronator quadratus, as Paul Mansky taught us. Sometimes I'll bring that and interpose it between the radius and the ulna. And I do almost always stabilize with an ECU hemislip. And I would say the technical pro I have for that one is you always need a longer strip of ECU than you think you do. And so you cut the ECU as far approximately as possible where you can get tendon or at least a hemislip of tendon, because you need every bit of it to get a good sling for that stabilization.
So I will say the one procedure I know that is done in the community that I probably will never, ever, ever do is an interosseous membrane reconstruction. That for sure. That is a hotly published topic, at least it was a few years ago, and I just feel like that's craziness. And then the other one that I did a lot of as a medical student, mainly because I was studying it in the lab, is the distal radial ulnar ligament reconstruction as described by Brian Adams. I find that is a surgery that it seems very technically difficult to make it work, and I don't think the papers ever reflect the level of enthusiasm that was originally there.
Well, I like both of those. And I know there are constantly updates on how to best reconstruct the interosseous membrane. I'm totally with you. I don't believe it's possible. Honestly, it's too complex of a structure. But I know there are techniques and newer techniques continuously being reported. And here's what I'd say to the Adamsberger reconstruction. I have done it. It is very rare, even in my wrist-heavy practice. And I would say that for me, the foveal TFCC repair, I don't want to say has replaced the need for that, but my understanding of the DRUJ and my need for a structural repair of the TFCC, that has increased. I more commonly do that with a foveal TFC repair, which I think has decreased the need for some type of tendon graft reconstruction. Not completely obviated it, but definitely decreased it.
I think the ability to tension that TFCC through the ulnar tunnel technique has taken the learning curve out of that treatment of that side of the wrist a lot. And I've by no means am I as an expert in the wrist, anywhere close to you, but that surgery has helped me as somebody who does those surgeries but doesn't do them a ton to stabilize that side of the wrist and help treat pain. What I would say is maybe one more surgery we could briefly discuss before we close out is the 3-ligament tenodesis for SL reconstruction. Again, a hotly published topic as recently as 5 to 10 years ago, but as we talked about in the literature update this year, has fallen a bit out of favor in terms of the ability to reproduce those results. Have you ever done that surgery, and would you ever do it?
I have done the surgery. I do not do the surgery, and I think we have institutional bias against the general concept of this surgery, and it's been modified, but the basic Brunelli, so to speak. And there will be a lot of listeners who don't understand our institutional reluctance, whether it's the original or the modified or the modified. But I have not seen good results, whether they be my own or others. It is a very complicated surgery. I like simplicity, but that doesn't mean simplicity is always the right approach. Yeah, I think it's a great example. Perhaps it's just something that we need to learn better, but I don't buy it. I just don't think it's the solution I'm looking for.
A lot of tunnels.
A lot of tunnels, little bones.
All right. Well, thanks for playing Wheel of Hand Surgery. I will take this Never Have I Ever with off. High-tech wheel. It's going away. And then let's have a listener send in a topic. handpodcast@gmail.com. You can hit us up at handpodcast on Twitter. Just let us know what you want to replace this little post-it with. And if it really is more sports, we can find a sports topic. But the sports topic that's on here has not been picked. So we'll see what happens next time.
It's not been randomly selected by Dr. D for some reason.
My wheel. We did pick a sportsy topic last time. So
slack wrist is sportsy.
So it happens when you don't do the sports surgery.
So I have one favor to ask. Please take good care of that wheel of hand surgery during your upcoming move. I mean, God forbid something happened to that.
This stays in my work bag, so it's tucked in a manila folder. Maybe I can't get it laminated because I got to keep changing these post-its. Maybe one day I'll get somebody to build us an actual wheel.
Perfect. All right. Have a nice day.
You too. Take care.
Bye.